Well, thank you for the invitation. I'm really happy to be here. I was asked, and I think it's my 4th time in Kuwait now, so it's really always nice to come back. And the reason I came back was that indeed there was this very nice invitation, so thank you very much again. And also because I think that this topic we are speaking about today is really a very interesting topic and a very, let's say, clinically relevant topic. It is about comorbidities and manifestations in the body of an autoimmune related disease like spondyloarthritis together with other autoimmune related diseases. And indeed the topic today will be inflammatory bowel disease related arthritis, especially spondyloarthritis. I added the subtitle, "Why do we need interdisciplinary approaches?" Simply because I believe that what we will see and discuss here, you will see, is very relevant for interdisciplinary cooperation. So, starting with it, I would just like to remind you that spondyloarthritis is just, or is an additional arthritis. So, I don't think it makes much sense to divide this whole topic to whether we speak about the periphery or about the spine. The symptoms and the way this, let's say, inflammatory signal is being transmitted is very, very similar, independent of the joint that we are speaking about. So what happens here is actually that you do have some triggers, and these triggers, I don't know whether you can see very nicely, these triggers might come out of the colon, and there is actually different peptides and different enzymes that actually lead the inflammatory signal. You might be able to see it from the very far away, that there is HLA-B27 involved in this part, and also that there is other interleukins that are involved, like here, for example, IL-23 or IL-17. And I'm saying this because you will see both now and in my next presentation at the end of this session that we are talking about treatments that really are targeting exactly these factors. So there is obviously not only a pathogenetic but also a treatment-related relationship between IBD, gut inflammation, and arthritis, especially spondyloarthritis. Now, speaking about general symptoms of arthritis related to inflammatory bowel disease, I've put here together those 3 or 4 more important ones. And I'm not saying that there might not be others that might now be more and more coming up as newer targets or newer manifestations, but these are the ones that we know best. So we're talking about not only arthritis, but also about arthralgia. There might be patients, and this is a clinically, I believe, extremely important problem, especially in females where we tend to diagnose fibromyalgia very frequently. So there might be patients who really have no swelling, but they have severe arthralgia. This is something to consider and maybe to ask in terms of asking for IBD symptoms in those patients. Although, of course, arthritis is also an important thing, and this here we mean pain with swelling. And the sacroiliitis part that I will discuss later on means the involvement of arthritis in the sacroiliac joints and in the spine, together with or without enthesitis. Now, how frequent is all this, what I'm telling you here? Is this something we would really have to consider frequently, or is there a dissociation between inflammatory bowel disease, inflammatory arthritis, and not so much something to really find together concomitantly? This is, and you see here, and I think it's very important to point out, this is a very old publication from 1998. And in fact, we don't have any other really very good results or studies on that topic. So this would be something maybe to consider for those of you who are interested in the topic, to also analyze also here locally and see whether these results can be replicated. Anyway, what they've done in this IBD clinic retrospectively was to find out many patients, more than 1,000 patients who had IBD, and ask them and also examine them about arthropathy, arthralgia, arthritis, and also what they used to call spondyloarthritis or ankylosing spondylitis back then. Now I know that some people here are not rheumatologists. You might be GPs or gastroenterologists or coming from other specializations. That's why I would just like to point out that what I call here ankylosing spondylitis is just one stage of the whole spondyloarthritis spectrum. Spondyloarthritis is patients with inflammatory back pain who might end having ankylosing spondylitis, but they might also have what we now call non-radiographic spondyloarthritis. This means exactly the same symptoms but no x-rays. So this here is something that we nowadays, not 1989, but in the year 2015, we would consider as being one disease, those two or four bars together. Anyway, what you can see here is that there is a considerable amount of patients who might have Crohn's disease and will complain about pain and swelling. And this is something we again need to take into account. This means that the problem is frequent. And you also can imagine that now, 17 years later, these percentages, these proportions might change in even higher numbers, simply because we have discussed with our patients about, or we have educated them about IBD, and the awareness is much higher. I think this is something we always need to keep in mind. I'm not going to go into every single detail about the clinics, but this is something that I believe is important to at least have shown once in each of these meetings that we are doing, and really, let's say, define exactly what we are talking about when we talk about arthralgia, arthritis, and all these kinds of immune-mediated inflammatory diseases in the periphery. So we talk about two types of arthritis, especially peripheral arthritis. I call it here arthropathy because there's not only inflammation but also pain, but in fact it's more or less arthritis. And it's type 1 and type 2, either postearticular, this means less than 5 joints, or polyarticular, means more than 5 joints. And you also see that in the polyarticular manifestations, there is more the smaller joints that are affected, and the knee or the big joints, the large joints, are more the postearticular type. So this is something, again, also to consider. Maybe this is something relevant to you when you diagnose or classify patients. Now, going into more details and speaking about our, let's say, main topic, or my main topic also, which is spondyloarthritis. One study, and I think it's also again important to point out that this is an old study again, and I couldn't find anything really more recent in the recent literature, has tried to find out whether rheumatic manifestations in IBD patients, so the patients that they took were IBD patients and then were examined for rheumatic manifestations, whether there was also a relationship or a correlation with HLA-B27. So here you see those patients who were, out of those with IBD, who had rheumatic manifestations, you see those who were B27 positive. So this is a pre-selection. And you see that obviously, indeed, there are many, many patients who have spondyloarthritis, especially the late stage ankylosing spondylitis. I will speak about the earliest stage in a couple of minutes. So obviously, we really need to take care about these patients maybe a little bit more, and maybe with a little bit more attention, because there seems to be a very strong relationship between IBD and arthritis of the spine, or spondyloarthritis, or ankylosing spondylitis in this case. Here you see again the type 1 and type 2 arthropathies, but anyway, the percentages, the proportions you see here are extremely high. This means that more than 50% of patients with IBD who are B27 positive might have spondyloarthritis. So how does this all now come up? So what is the, let's say, the trigger to develop spondyloarthritis or arthritis out of a patient who has gut inflammation? Here are, again, without really explaining this into too many details, nevertheless, here are some of the, let's say, theories that we believe that exist about how this all works. And in fact, you all know that spondyloarthritis might be triggered by many different mechanisms, independent now of the gut, also by stress, also by accidents, also by infections. And one of these triggers might also be microorganisms that have to do with the gut. especially when there are some antigens that really trigger the already existing family predisposition. What do I mean by that? I mean, I go back one slide. I mean that if you have B27 positivity, you have a lot of chances to develop spondyloarthritis, and this might be indeed due to the fact that there is cross-reactivity through antigens, and I showed you before the slide that B27 is involved in this whole process. And B27, what does it do? It actually initiates the excretion or the secretion of interleukins like IL-17, like IL-23, like TNF-alpha. I do know very well, and this is something we have to discuss together because I would like to know your opinion later on, that there is differences in the prevalence of B27 in different parts of the world. So the question would be, does this, what I'm telling you here, also apply locally? And do you think, or do you have an experience that this might be different here in this part of the world as compared to, let's say, Sweden or Norway, where they have higher B27 prevalences? I don't know. But at least these are the data that I can show you, and whether this applies everywhere in the world, we need to discuss indeed. What nevertheless is, I think, very important is that we have learned a lot, not only from the studies that have been done retrospectively that I showed you before by humans, but also we have learned a lot from animal models. This is just one example of how this can happen. If you take a TNF-alpha or a TNF transgenic mouse, which is a prototype of mice, of mice that are being used in experiments to show and induce inflammatory activity in the spine, you will see that there's it might imitate human disease, that there's actually the inflammation in the mouse, which really leads to sacroiliitis, enthesitis, so large joints, small joint involvement, and Crohn's-like ileitis. So obviously there is a concept. Again, whether this only relates on B27 and whether this can be transmitted to everywhere in the world, I don't know, but these are the experiments we have so far. So being more clinical now, and I think this is the next part of this presentation, being more clinical now, we do know that independent of what is happening and why this is happening, the spondyloarthritis concept indeed includes IBD. And I'm talking about a concept here, so we really need to pay attention to the words. A concept doesn't mean that we know exactly what is happening. A concept means that we have put information together that lead us to a diagnosis. I think this is very important to keep in mind. We know that all of these patients at some point will end up having ankylosing spondylitis, or the majority of them. And again, this kind of spondyloarthritis, either you call it undifferentiated or early stage, whatever, is also associated with IBD. And the question again is, how does this go over here? Some of the ideas I showed you before, but the concept says that clinically this is something to consider. So obviously diagnostically we need to take care about the patient as a whole, let's say as a concept, and the concept really includes many different aspects: back pain, arthritis in the large joints, arthritis or enthesitis in small joints, eye disease, imaging, inflammatory markers, and also IBD, together with other reactive arthritis types, like, for example, chlamydia and so on. So obviously, diagnostically, IBD is of importance, and also prognostically, it makes sense to use it. We do know that if you look at this table and you go for the likelihood ratios that you see here, the positive likelihood ratio, the negative likelihood ratio to have the correct diagnosis, IBD is here. So the likelihood ratio to have spondyloarthritis if you have chronic back pain in IBD is 4. This is 400 times increased as someone who has only back pain without IBD. So obviously, not only diagnostically, but also prognostically, IBD is of importance. What I explained so far is how this concept works, why this is important, because it is obviously frequent, and because obviously it also leads to the diagnosis. And now I will try to show you the proportions of patients that might appear, so the clinics the proportions of patients that might appear with gut inflammation in spondyloarthritis and vice versa. So taking into account now that we're talking about an extra-articular manifestation that might lead to articular manifestations later, we see here that about 40% of the patients with spondyloarthritis might have some kinds of other extra-articular manifestations. IBD is red, this is about 20%. So 20% out of those who might have spondyloarthritis are clinically apparent IBD patients. Again, a very old study. You see it here, 1991. And it appears actually pretty really interesting to see that these data have not been tried to be replicated 20 years later. Now we are starting again to replicate them because we have a special interest, and I will show you later why. But nevertheless, our knowledge really is based on very, very old data. And what they did there in Ghent, in Belgium, that you might know the Belgians have really a very high interest in IBD-related spondyloarthritis. So this was the very beginning of this research. So what they did there was to take patients who underwent ileonoscopy, patients with spondyloarthritis. And to find out, by the way, all these patients did not have to have symptoms. They were just having spondyloarthritis. They found out that 40% only had normal gut histology. 60% did not have it, which is extremely important. And you see that 25% of the patients had acute inflammatory lesions without symptoms. And those 34% were with chronic inflammatory lesions. So the question is, how can we identify these patients early enough? Or let's say it differently, is this important? And if this is important, how can we identify these patients early enough? There's another study that comes from Denmark. And this is a study at a similar time, 1994. I'm not going to read all this. In fact, what you can really see is that they found IBD diagnosis in 20% of the patients. And in SPA patients, this was much more frequent as compared to other arthritis. They took all the arthritis patients together. So SPA, IBD-related SPA or SPA-related to IBD was very, very frequent. And especially, and this was the start of the whole story, ileal changes were found only in SPA. That's why we say always that we really need to see the ileum in patients with spondyloarthritis in order to say that this colonoscopy has been done properly. What I think is also important for you and also for discussion with me later on is this one, that they found that there was no association of gut lesions and the use of non-steroidals. This is something that I, at least in Germany where I work, gastroenterologists do not really believe in. And they always say that in patients with spondyloarthritis, we should not be giving non-steroidals. You will see later that non-steroidals, so ibuprofen, diclofenac, and all these drugs are a key treatment option in spondyloarthritis. And this is again something we have to discuss on whether you see it similarly or not for giving these drugs to these patients. So, what are the newest data? The newest data, and I told you that there have been some newest data now, after at least 20 years. The newest data actually analyzed 156 publications that kind of dealt with this topic, not entirely dealt with this topic. And they found that about 7% of patients with AS suffer from clinically apparent bowel symptoms. And also there was uveitis and psoriasis, but this is what we are talking about here now. So clinically apparent bowel symptoms. And the other way around, this was the same group, by the way, that published this data. 27% of IBD patients suffer from axial spondyloarthritis. So who is the key physician now? Is it the rheumatologist who has to ask for IBD symptoms? Or is it the gastroenterologist and the GP who, in a patient with IBD, has to ask for peripheral symptoms or axial symptoms? We still don't know, but this is something I think very interesting clinically. So obviously, by the way, the PSPA means peripheral SPA, AXSPA means axial spondyloarthritis. This is 40% of patients, even more than this 27% that I mentioned before, 40% of patients who have any kind of spondyloarthritis symptoms. So assuming now that there is a high prevalence of both diseases in each other, the question is also, what kind of inflammatory bowel disease do I really expect to see? And why is this so important? So why am I speaking now for the last 20 minutes to you and saying that IBD and SPA are linked to each other and this is something to consider? Obviously, and these are also data coming from Belgium, from the same group that I mentioned before. Obviously, 46% of the patients who they had with axial spondyloarthritis classifications, this involves also the earlier stage, now had gut inflammation that was clinically silent. So I was speaking about clinically apparent IBD, now I'm talking about clinically silent IBD. So this is pretty interesting, I believe. They divided patients who had peripheral spondyloarthritis, early stages of axial spondyloarthritis, and late stages of axial spondyloarthritis. And what they found out was something also to me, who is seeing these patients very frequently, was very new. They found out that the chronic disease that I also mentioned before, the chronic IBD lesions, clinically silent, are more associated with ankylosing spondylitis, so the really late stage of the spondyloarthritis. While acute IBD, or let's say acute gut lesions, inflammatory lesions, was similarly seen in non-radiographic axial spondyloarthritis, as well as chronic lesions were seen here. So obviously, the more chronic the gut inflammation is, the more chronic also the spinal disease will be, which is something we have to consider as well when we interpret gut inflammatory lesions. Which are the risk factors now for bowel involvement from the rheumatologist side? And this is something I have to tell you because I don't know very well, at least the IBD, the gastroenterology side, but what are the risk factors for developing bowel involvement in patients who have established axial spondyloarthritis? These are 3. Young age, male gender, you see here the odds ratio, and disease activity. So for those of you who are rheumatologists, this might ring a bell. This is a typical spondyloarthritis patient. A male patient who is young and is having high disease activity is a typical spondyloarthritis patient, or the patient that I will typically give a diagnosis, meaning that obviously, indeed, I go back, both acute and chronic gut lesions may be seen early enough, and these are clinically silent in patients with spondyloarthritis, or in other words, when I see a patient with spondyloarthritis, I have to think about inflammatory bowel disease that is still clinically silent. And the pretty interesting thing, in order to translate this into clinics, was imaging. What they found was that the inflammatory activity in the gut, especially the chronic one, was very much associated with inflammatory activity in the sacroiliac joints in the MRI. So obviously, the more inflammation we have in the sacroiliac joints, the more clinically silent gut inflammation can be expected. There's another thing that I found very interesting. This is a small publication that was published in the Journal of Rheumatology 3 years ago, where they found that not only this might be important or interesting, inflammatory activity in the sacroiliac joints, but also a specific finding in the spine might be very well correlating with IBD. And this was, I show it here, erosive changes. Why do I point this out so much? Because we know that erosions are not typically seen in spondyloarthritis. So this leads me to the conclusion that if I have a patient with spondyloarthritis and I do the spinal MRI and I see a lot of erosions, this might also be something to consider for this patient having a clinically silent IBD. Now, what about treatment? And I will not take too much time to talk about treatment because I will speak about treatment of spondyloarthritis later on. Nevertheless, this is something to consider when we have patients with IBD. As I mentioned before, IBD and spondyloarthritis, of course. As I mentioned before, there might be also painkillers and also non-steroidals that are important. And the question is again, how much of non-steroidals can we give in those patients in order to not worsen their clinically silent, yet silent IBD symptoms? Glucocorticosteroids might be useful, might be given by the rheumatologist for any kind of arthritic symptoms, but we know that they are not really useful in patients with spondyloarthritis, or they might be useful, but they are only useful in very high doses. That's why I would exclude this. Sulfasalazine, we use it in spondyloarthritis, especially in those patients who have peripheral symptoms, and this is something to consider as a concomitant therapy in patients who have IBD, but again, we can only give it if there is an apparent, clinically apparent symptomatology. In clinically silent patients, there is a kind of a risk to overtreat patients. Anyway, how do we use now the recommendations for treatment for spondyloarthritis, and how can we apply them to those patients who have SPA plus IBD? This is the treatment algorithm that I will show you in my next presentation as well. When it comes to treatment, we again start with NSAIDs, and especially in those who have axial disease, we would use biologics. So far, we only have TNF blockers in this case, or in these patients. And again, the question to you, especially those of you who are gastroenterologists, can we use NSAIDs or can we use COX-2 inhibitors in patients who have spondyloarthritis and IBD, yes or no? Since, as I mentioned before, this is the very, very first drug or compound we're going to use anyway. So is this still safe to do it in patients who might have a lot of inflammation, as I showed you before, who are candidates for having IBD silently or not? Well, I'm using two studies that I have found in the literature. I haven't found any others, but there might be others that I might have missed. So please correct me if I'm wrong, but as far as these data show it, especially when it comes to a COX-2 inhibitor, there is absolutely no risk of giving this COX-2 inhibitor in patients, even if they have IBD, clinically apparent inflammatory bowel disease, in order to treat their axial symptoms. So we don't do any harm to these patients. I need to mention, by the way, that all these drugs, non-steroidals and COX-2 inhibitors, at least in rheumatology, need to be given high dose from the very beginning. So really use the maximum dose. And that's something that I believe is, for the rheumatologist, a very important information. Obviously, there is no increase, there is no difference in the flare rates of IBD if you compare it with placebo. And the other study that has been done was done with a celecoxib, so another COX-2 inhibitor, and also here there was no difference in the flare rates. Here you see a different way of assessment of the flares. This doesn't mean that we have 10% versus 4%. The assessment of flare rates was different. That's why the differences in numbers. What I want to say is that obviously there's, at least for the COX-2 inhibitors, no increased risk. And we are, at least in rheumatology, able to use exactly this algorithm to treat our patients with or without clinically apparent or silent IBD. Now, going back in time a little bit about TNF blockers and biologics, I'm showing you one of the very first studies that have been published when it came to biologic treatment and TNF blockers especially. This was done for Crohn's disease, and we knew from about 2 years ago, this was published in 2002, we had published in Germany the very first study in ankylosing spondylitis about infliximab, and later on also other biologics came into the market. So obviously biologics are efficacious in patients with IBD, here especially in those with Crohn's disease. Here you see it in numbers with a 10 milligram per kilogram dose every 8 weeks. Here you see it in an image, obviously very good response in both the clinical symptoms, but also in the clinical symptoms of the spine, but also in the clinical symptoms of the bowel. What I think is very interesting to see was obviously that this effect was especially in patients with spondyloarthritis, especially seen in those patients who also had a good response on articular symptoms. So the swollen joint count is being shown here on the right side. This is the CRP, so this is a two-way method to look at this table. And whenever the CRP and the swollen joints were down, also the clinical, whenever the CRP was going down with infliximab, also the swollen joints were going down. And whenever there was an increase in the inflammatory markers, also the swollen joint count was going up. This means that the symptoms of the bowel, let's say the response to the bowel, was also correlating very well to the musculoskeletal symptoms. And we of course know that there is other data that has shown that also other biologics work in Crohn's disease. So here the comparison, or not the direct comparison, but at least the data of infliximab and of adalimumab. We had actually published a paper in 2005 that showed that there was a difference between the monoclonal antibody of infliximab and etanercept and adalimumab. Here I would not really take this data for so, let's say, seriously, simply because we didn't have so many data on adalimumab at that time. I think this here shows more the truth. This means both monoclonal antibodies seem to work pretty well. However, we do know that at least the fusion protein etanercept does not work in IBD, although it works in ankylosing spondylitis and in psoriatic arthritis. Here you see, let's say, a summary of how this treatment might be working and what we're doing with the patients. You see also the dose comparisons, which is pretty similar to IBD. So obviously, what we're using in rheumatology can be applied also in gastroenterology. Now, what about new treatments? And I mentioned before that there are also some other, let's say, targets that we might be targeting nowadays in rheumatology and might be used or might not be used in patients who have IBD-related symptoms. Especially IL-17 is of interest and of importance, simply because this drug, IL-17 inhibition, will be coming into the market in a couple of weeks. I don't know when this will come here to Kuwait, but we will have it in Germany in the beginning of 2016. And we need to know exactly if we treat patients with axial symptoms who might have silent IBD or others who might have also apparent IBD symptoms, whether we are able to use IL-17 inhibition or not. So obviously, the first data that have been published so far have shown that unfortunately these compounds do not work in IBD symptoms, and we are indeed very much limited to TNF blockers. Here is a very, let's say, brief summary of what is being done, what has been done in terms of treatment of inflammation, either by treating TNF alpha or IL-6 or IL-1, IL-12, 423 or 17A, and as you can see here, this will be green from next year on. As you can see here, the TNF blockade is still the gold standard when it comes to treatment of all immune-mediated inflammatory diseases, the way I mentioned them so far. I believe that the future is going to be like that we might not be speaking about diagnosis anymore at some point, but we will be speaking about whether there is or there is not a response to a treatment. And this approach here that was published some years ago, I find it very, very interesting and very important, meaning that starting with the TNF alpha, but of course there will be also others, as you see here, other targets that might be involved here. TNF alpha might be one kind of, let's say, inflammatory activity, which is, by the way, or at the very end, being treated for all the diseases, but we might be able to do a taxonomy to really categorize diseases not by their diagnosis, but by their inflammatory marker, or at least target that can be used in treating them. This is again something to consider. We need to see whether this will be established, but as an idea, I find it very, very interesting. And in order to finalize this is something we all together can put together for the daily practice. I don't know how well you can see the readings here because it's a little bit small, but I will guide you through this. This has been published many years ago and still valid in terms of how to really go into the clinics. Speaking about a patient who has ankylosing spondylitis with somehow a probability of IBD clinically apparent of 5 to 10%. You remember it's 50% for the clinically silent IBD. And then asking on whether there are bowel symptoms, yes or no. If there is no, then there is no need, at least at that time point, this is what we thought, and we still kind of think, to do a ileonoscopy and then treat IS as appropriate, either with NSAIDs or anti-TNF. And if there is a bowel symptom, then this here says at least that we should do a ileocolonoscopy. And if there is Crohn's or ulcerative colitis, then we should focus on the concomitant treatment of IBD and spondyloarthritis. Maybe avoid NSAIDs. I showed you that there's data that say the opposite, and then start with TNF blockers. If there is no Crohn's or ulcerative colitis, then we need to check for subclinical gut inflammation And if there is subclinical gut inflammation, then the treatment is very similar. If there is no subclinical gut inflammation, then we should focus on spondyloarthritis. That's actually pretty straightforward. Now, what is new? What is the very new things that I would like to show or share with you when it comes to the treatment of spondyloarthritis and IBD? These are really unpublished data. I will show them to you, but I would just like to mention that these are things that still might change a little bit because we really need to review them a little bit more carefully. But they have either been shown in meetings like the ACR meeting 2 weeks ago, or have been proposed but are not published yet. And one very important thing is the role of calprotectin in IBD and whether we can really assess calprotectin and inflammatory activity in inflammatory activity of the gut in patients with spondyloarthritis. This might seem too complicated. Actually, it's pretty easy to read. Here you see the calprotectin levels, which might be low, either in the serum or the fecal calprotectin. So both are being considered here. Here you see in green and blue the normal biopsy or the inflammatory biopsy or inflamed biopsy of the gut. So this is normal, this is inflamed. And here what you can see, in fact, is that you might have inflamed gut histology in those patients who have elevated either serum or fecal calprotectin, or with or without combination with CRP. This means that obviously we have this new marker, calprotectin, which seems to be important in daily practice. And what is being proposed is that in patients who have spondyloarthritis and have both CRP and serum calprotectin elevated, then it would be independent of symptoms. Important and interesting to consider a colonoscopy. If one of both is elevated, then we could do the fecal calprotectin. If it is increased, then colonoscopy should be important. If it's not increased, then there is no further action required. And if both are low, CRP and serum calprotectin, then there is no further action required either. So obviously, calprotectin might also lead clinical guidance in terms of treatment, in terms of how let's say, to go on from there and try to find out whether the patient has a silent IBD or not. I took this from a photo that I made at the ACR, and actually this shows very nicely what the consequence of this here might be. One of the consequences might be that we might consider, not because we want it, but because patients will need it, treatment with a TNF blocker even earlier. So obviously this shows that patients who have spondyloarthritis have a normal gut biopsy, independent of the calprotectin levels or not. So assuming we have gone that far and we've done the colonoscopy, then they will not need the TNF blocker as fast as those who have either acute or chronic inflammation. And you remember, acute and chronic inflammation might be seen in different stages of spondyloarthritis. Nevertheless, here there is no difference in between those two groups, but there is a group as compared to the normal bowel histology. So I go back one. If we have, again, consider colonoscopy because CRP and serum calprotectin has been high and colonoscopy was positive, or because one of them was positive and fecal calprotectin was high, then we might consider the treatment of the patient even more rapidly and more aggressively. And the quite interesting thing is that obviously this was shown in the same presentation. It was obviously that after 3 months, exactly those patients who will be treating earlier will also be the good responders to TNF blockers. Bowel inflammation positive, normal histology. You see that also those, because they had symptoms, showed improvement, but almost 90% of those patients who also had inflammatory bowel disease were showing a very good response already after 3 months to TNF blockers, which means that we're really going towards to more individualized medicine, also by considering the serum and the fecal calprotectin levels as one of the main triggers for not only bowel disease, but also for treatment response later on. And by this, I would like to end my first presentation. Thank you very much for your attention. And the question is, do we take questions now or later? Later. Thank you.
Thank you.